which she wouldn't wear either, because she said she couldn't stand the sound of her husband's voice and her heels going on the floor. So it's an adjustment. They go from not hearing to all this sound. And when we're listening to a conversation, if you and I were talking and they were talking, I could block that out and listen just to you. But when you have a hearing aid, you can't necessarily block things out. You hear it all. So it's very different kind of hearing. They don't want to be embarrassed, so they don't want to wear it. And we talked about the high frequency sounds.
What Rebel says the various people that their kids use in marriages have to wear a hearing aid because you can just turn it off.
Yeah, right. Dang, I've been married 38 years this year. My husband might need hearing aids. He really does. So we're going to talk about Meniere's disease. Does anybody know anybody who has Meniere's disease? Almost every class has somebody who knows someone who has it.
I think Miss Campbell has it. I think she told us that in class.
Okay.
She said it in lecture on LP.
Okay. So do you know what it is? What the symptoms are? You know anything about it?
Tinnitus.
Okay, tinnitus. What does that mean? Ringing in the ears. What else? Vertigo. Vertigo is the big symptom. Like if you look at this, when they stand up, this is what they see. Everything's just spinning. It's very severe. It's debilitating. Okay? What else?
They have a lot of ear infections.
Okay, they don't have a lot of ear infections. Although I can see why you would think that, because this is what the problem is. If this is my normal healthy ear right here, you see this the canals and the labyrinth of fluid. Well, what happens in this, it gets fluid, but it's not in the inner ear. It's actually in the labyrinth, and it's systemic. So it doesn't cause ear infections. When you have an ear infection like from swimming, that's all in this outer part of the ear, not right in the actual labyrinth of where the fluid is. Mm-hmm. It's right here. Let's get that. It's right here. See how swollen that is? This is all swollen. The backed up fluid leads to pressure, and that's what distorts everything. What cranial nerve is for your ears? 8. So it affects cranial nerve number 8, and that affects your balance too. So these people have tinnitus, they have dizziness, and they have a lot of balance issues. Yeah. Why are you way ahead of me? Whose notes do you have? We're going to talk about it.
I thought maybe it was a typo or something.
No, it's the type of diet that they're supposed to be on. Y'all, I'm going to say something real quick about this notes you get from generations of other nursing students. Level 4, y'all know, because I know nothing's a secret in this whole building, did terrible on their last test.
Absolutely.
And they think we're out to get them. We changed all the questions and we made everything harder. Let me tell you what we changed for cognition for level 4. We took our questions from fall of 18 and we moved them over to fall of 19. And we do now have to have 6 distractors on a question that's a select all that apply instead of 5. So Ms. Bates and I sat down and we wrote a 6th distractor for one select all that apply and a 6th option for the other select all that apply. Those are the only changes that we made. The difference is they have notes for generations, and not one person in that room picked up a pencil to take notes, and they couldn't have cared less if we were there because they already had everything they needed, and you see how it worked out for them. And I'm not telling y'all anything that I haven't already told them. So I'm just saying, don't trust people's notes unless you know that they're good. Don't trust them to give you the information you need, because I promise you, I won't let you leave here without what you need if you listen to what I'm saying, and trust me for your notes instead of your friend.
So I was just looking at the syllabus for this cognition, and it says chapters 41 through 45. And Meniere's is in chapter 48.
Correct.
So I haven't gone and read that chapter. So just jump around.
The only thing you're going to read in the ear chapter is Meniere's disease.
Okay.
I don't care about any of those other disorders. If you look at your syllabus, it says corneal transplant, retinal detachment, Meniere's disease. That's all I care about in those 3 chapters.
I just wanted to make sure.
Yeah. You might have to go back and look at the AMP chapter if you don't get it, if you don't understand why it's happening. But other than that, only look at those 3 things. Okay? So that's all that's on your syllabus. So there's a little video link at the bottom of this that you guys can watch if you want to watch what the patient goes through and stuff. But this comes from this distorted swelling that changes the sound and changes the balance and changes information going between the ear and the brain. So that's the cause of it, the increased fluid. We go back to, I don't want to forget anything. So, a person with Meniere's disease does have vertigo. They do have some trouble with balance, because you can see if you stood up and that's what you saw, and you might lose your balance for a minute. What else do you think they might have problems with? Nausea. Nausea and vomiting is a big issue, because you have that dizziness all the time. So nausea is a big issue. Driving. Should this person be driving? No, especially if they're having an exacerbation, because this can come and go. If this fluid gets under control and is decreased, they're not going to have the symptoms as severe. But if you're having an exacerbation of Meniere's disease, you should not be driving the car. What else? You might have some headaches from it. What do you think your ear feels like?
Pressure.
Yeah, pressure. Lots of pressure. Not pain, but lots of pressure and fullness in the ear.
Like swimmer's ear
Kind of like swimmer's ear, but swimmer's ear is painful though. You can hear the swishing when they move their head. You can hear the fluid moving.
This doesn't actually hurt them. It's just like annoying.
It's annoying.
Okay.
It's annoying, and the symptoms are what causes your safety problems. The other thing is progressive chronic hearing loss. So each episode, the hearing gets less and less, and they have chronic hearing loss over the period of a lifetime. So that's something to think about when you're having that. Is there a cure for Meniere's disease? There's no cure. There's some treatments out there, and there's some options that the client has, but there is no cure. It's an ongoing problem. Once you develop it, you got it. Yeah.
So the exacerbation.
Just the lymphatic system in your ear. Not working. What'd you say?
Does Dramamine like help it at all?
Dramamine is one of our drugs we're going to talk about. Yeah.
How do you get it? I literally saw something.
Is it a lymphatic problem in the inner ear? It's not an infection. It's not an infection. They don't really know what causes it. It just happens. There is a genetic component. If someone in your family has it, then there's a higher chance that you'll develop it.
Is there any testing that they can do since it's a genetic test?
I don't honestly know. I don't know that. There's a genetic marker. Well, this is their main treatment. It's this high drops diet, and it's really a diet that's high in grains and low in salt. Yes.
So it's characterized by exacerbations and remissions. If they're constantly in a state of this, it could be a different problem, or?
Yes, there's usually remissions. There's usually remissions, because if it gets so severe, what are you going to do? You're going to take the medications, and you're going to follow this diet, and there's also some, not yoga, it's not really physical therapy, but there's some exercises and some positioning movements that they can teach the patient that help with the drainage and will decrease the symptoms that patients say work better than anything else.
Is there something that triggers that? Like, I mean, is there a trigger? Like,
No, but they say the high sodium diets that we eat will cause an exacerbation. And that's what this is. It's really fruits, vegetables, whole grains, cutting out all the salt. They want the salt less than 1,000 milligrams a day. They want you to drink adequate amounts of fluid because you need fluid. Caffeine. They don't want you to drink caffeine because what does caffeine cause? Fluid retention. It causes fluid to come into the vascular system. So avoid caffeine foods. Avoid alcohol. If you do drink, limit it to 1 glass of beer or wine a day. The other thing that's a real trigger to this is MSG. Where do you find MSG? Chinese food and all the restaurant food that tastes really good has MSG in it. So MSG is a problem. So your patient needs to learn to read food labels to make sure there's not MSG in whatever they're eating, because that's a big trigger for this. That's the diet they want the patient to follow. Patients will tell you, it really, really works for me, or I don't see any difference at all. So it's hitting this.
So we need to like avoid loud noises, like concerts or whatnot, does that make it worse, or?
No, it's all fluid related. Everything's related to the fluid. I would imagine that going to a loud concert when I'm not drunk, I have Meniere's disease. I just don't think that would be a good combination, falling down the stairs. No, they don't say to decrease the fluids though. They want you to have adequate fluid intake, because if you don't have the sodium and the MSG, you're not retaining the fluids, so it shouldn't be a problem. But they're diuretics, they would get rid of fluid, so they'd be okay. Yeah, they'd be okay. But it's the whole grain and the fruit and the vegetables, eliminating all processed food, because what's processed food high in? Sodium, and that's what you're trying to avoid. The sodium balance is what you're trying to avoid. Here's your medications for this. And I didn't bring the syllabus down here with me, but I want you to know big, broad classifications of these. So this is these are the ones I really want you to know. The antiemetics. What does Phenergan do to you, and enapsine and thorazine? What do they do fluid-wise?
They retain.
They dry you up. They dry you up. So if you're taking the Phenergan, they dry you up. Let me ask you this. Who has ever had Phenergan in here? Who's had Phenergan IV? What does it do to you? It makes you tired. It can make you really, it does, the pill does? It can make you really dizzy. So if I already have these symptoms of dizziness, and then you give me the promethazine, I don't really know if my symptoms are better or worse. But if I'm nauseated, I'm going to take these antiemetics right there, because I want to get the nausea under control. Antivert, how many of you have given meclizine in the hospital? Because a lot of patients take it. Meclizine is antivert, and that is the one pill that they give for vertigo. But what I really want you to know about these medications is this. If I already have this patient who has dizziness and balance problems, and I'm giving them medications that are going to dry them up and make them loopy, dizzier, do I have some safety issues? So we're in the hospital, you got all that junk all over the room, SCDs and an IV pump, and oh, there's a Polaris right there. What do I need to be thinking about? Falls. I need to be real aware that this patient's at high risk for falls. And they can't be driving cars when they're taking these medications on an outpatient basis either. What does atropine do? It dries you up. So what's it do to you? It can make you dehydrated if you have enough of it in your system. So that's what I want you to know about the medicines. Just know that with these medicines, there's all kinds of safety issues. Know this one for sure, meclizine, and then know these antiemetics. Can Benadryl have an adverse effect on old people? Yes. So if I have an older patient and I give them Benadryl or Tylenol PM, because I don't know if y'all know this or not, but old people do not read. So they don't realize that the PM part of Tylenol PM is Benadryl, and it makes them a little bit goofy and a little bit staggering gait when they get up. Is that helping my problem or making it worse? Right, it's making it worse. So just be able to recognize the names of those drugs. I gave you the brand name too, so you'll know what it is. And know that safety issues with those drugs in your patient, you want to keep them safe. The positioning with this, they do it through physical therapy, and they teach them all these positions to decrease the amount of fluid in their ear by helping open up drainage and stuff. Patients say that does work the best. If this becomes debilitating and your patient has no relief from it at all, they can do a surgery called a labyrinthectomy, where they take out this whole piece right here of the ear. Here's the problem. As soon as they remove that, your patient is deaf in that ear. So your symptoms have to be really severe before patients will agree to have that surgery. And a lot of times, patients who have this have it in both ears. So if you do it in one ear and then the other gets worse, you could be permanently deaf, both sides. So that is in surgery. It's done outpatient too, and they go home the next day. I've never actually seen this procedure done, because it's hard to get patients to agree to that.
Hearing aids,
There's nothing there to project the sound.
Yeah, it's get pretty bad, you might wanna do that.
I don't know, if I was busy all the time.
Right, I think if it was seriously debilitating where you couldn't do anything, because they literally, if they're having an exacerbation, cannot hardly take their head off the pillow without the room spinning. So, but that's the problem, it's permanent deafness in that ear. So, you think you can send this person out? Teach them something? Okay, that's a good point. Jacob said it would have to be written. You don't know sign language that quick? No. I think that if I was dizzy enough and vomiting all the time because of the disease, I would have the surgery too. But I've never seen the surgery done. I've never seen a patient who had it done. That could partially be because it's usually done in an outpatient setting, and I've always worked in inpatient settings. But even where I am now, part-time, we do ears and throat surgeries all the time, and I've still never seen this done.
You talked about positions, is there any certain positions that relieve the pressure? And make it feel when
Isn't it like you sit like on a bed with your head at a certain angle and then
Yes.
you throw yourself backwards?
It has to do with the angle and the speed with which you can move your head, and it shifts the fluid. I'll see if by Wednesday I can find a video to show you what it is, but it's some sort of positioning, and a lot of patients say that it works. So, I mean, I would try that before I do the surgery for sure.
I would try
I try exactly. I try everything before I do the surgery for sure. So, but when you're looking in those ear and eye chapters, I don't want you to read the whole chapter about pink eye and all that kind of stuff. You learned about that piece, right? I want you to read about corneal transplants and how to take care of that patient. It's a total of maybe 5 pages. I want you to read about retinal detachments and how to take care of that patient. And I want you to read in the ear chapter about Meniere's disease. Not ear infection.
That's less about the diet, but we can look that up from your slide.
Yeah, well, I just put that in there because you need to know that. It isn't in the book though. The high drops diet isn't in the book. So the ear and eye things, fairly simple, right? Okay, good. So we're gonna talk about traumatic brain injuries. You talked about this a little bit in level 1. We talked about mild head injuries, remember? We talked about mild injuries. I see a lot of LPNs in here, so I see faces that aren't recognize. We talked about head injuries in level 2. Like hit on the head with something. We're gonna talk about those here. This right here, I just want you to see this. You don't have to memorize this or anything. I just want you to think about these things. If I have a primary injury to my brain, be that a stroke, or a whack on the head with a baseball bat, or a brain tumor, I've got something there that's not supposed to be there, and that's my primary trauma. So my damage to my brain tissue is caused either because I have damage to the vasculature, meaning I have a bleed, or I have a blockage and I'm not getting any blood flow, or I have actual damage to the brain cells. Does that make sense? If I don't do something about those things, then I'm going to have all of these things. I can have a bleed right here, or I have increased intracranial pressure. If I have too much bleeding, I have that permeability of the blood-brain barrier that is not there anymore, and it starts to leak. Well, if my blood vessels start to leak, what's that doing to the pressure in my head? Increasing it. So I have edema. If I have vascular damage, I can also have ischemia, like your ischemic strokes you talked about yesterday at your class. And all of those things right here lead to necrosis of the brain tissue. So if I don't take care of this way up here at the primary issue, and I have all of these other things happening, eventually brain tissue is going to die. So that's why we care about this. We're not going to care in here about increased intracranial pressure though, except for what I tell you to care about, because you're going to care all about that level 4, okay? So I'll tell you where the stopping point is in the book so you don't get lost, okay? Well, I know, the book's, kind of schizophrenic, It's all over the place. You get lost. Why should you read 80 pages that don't pertain to anything on your syllabus? That makes no sense. Huh? It doesn't make any sense. Okay, this is just a review. Remember closed head injuries? Which one's worse, a contusion or a concussion? Concussion, because the contusion is just some bruising, but the concussion means I had some blunt trauma banging around. I might have hit the steering wheel and then my brain hits the back of my skull when my head comes back. What does this one mean? Diffuse accidental injury.
Isn't that when it shakes?
Yes, it's like shaken baby syndrome. Yeah, shaken baby syndrome, where I have the shearing and the tearing of the brain tissue. And then we talked about fractures last time, and I know you talked about some fractures in mobility, but you can have compression fractures, like if I hit you on the head with a hammer, you're going to have the compressed skull with the fracture. You can have penetrating fractures with a bullet hole or a knife wound, being impaled on something. So that's just a complete review of primary brain injuries, the easy ones. What do I care about? ABCs. I care about ABCs. If I have somebody who's hit on the head, the first thing I want to make sure is that they have an airway and they're breathing. Because I can have an open airway, but if I'm not breathing at all, I still have a problem. So airway and breathing come first. Circulation. How am I going to assess circulation in the parking lot? I don't have a blood pressure cuff. Okay, pulse. I can check pulses. Cap refill. I can look at color. I can look around obvious for signs of bleeding around their, head or whatever, if it's a head injury. So you can get some vital signs. Respiratory rate, you can get a heart rate. Level of consciousness, Glasgow Coma Scale. Ooh, do you remember how to use that?
Yes.
Sort of.
Oh, wait.
Okay, you're gonna see it. We're gonna do it with strokes. I'll pull it up there with the stroke, when we do the stroke scale next week. But the Glasgow Coma Scale, remember we score the client from 3 to 15. Which is best, 3 or 15?
15.
15. 15 is best, the normal patient. If I'm dead, what do I get?
3.
I still get a 3, even if I'm dead. So I'll make sure that that's in the slides for next time that we look at that. But the Glasgow Coma Scale is what we're going to use to assess their level of consciousness. Why do I care about that with a head injury? Okay, how much they can speak. Right, it determines, are they awake, alert, and oriented? Can they follow my commands? Well, what, does it assess breathing? It says eye opening. Do they know I'm here, or do I have to physically touch them for them to know that I'm here? Can they follow commands? Now, if I go in the patient's room and I say, could you turn your TV down so I can listen to your heart rate? And he immediately turns it down. Do I need to say, let me get out my scale and turn that on? No. I've done the assessment part, but I don't have to have the formal paper in front of me. He can follow commands. Or can you move your drink out of the way? If he can do it, then I know that you can follow commands. And what's the other thing that it assesses? The verbal response. Yes. When he's talking to me, is this a conversation that makes sense? Or is he talking about the 4th of July and it's Christmas Eve because he's kind of out of the program, what's going on? So yes, eye-opening, appropriate or inappropriate verbal response, and can he follow commands and move his extremities? So those are the things we want to look at. The reason we care about that, and whether they were unconscious or not unconscious, is because that's how they grade head injuries from mild, moderate to severe. The longer the loss of consciousness and the period of amnesia that they have after the incident, the higher grade the head injury is. So the longer the loss of consciousness, the more severe it is. So if they're completely unconscious and they score a 3, that's not good. It does, yeah. On the scale, it on movement, a 2, 1, and a 0 are the movement. We'll look at them next week when we have that on the other slide. So you guys take a break and come back at 2 o'clock and we'll Did